this is where I'm coming from. This is one of my own patients. He's a victim of violence. He was injured with a Stanley knife, so the motivation for getting involved in violence prevention is to prevent injuries like this. Now, I know, looking at the delegate list, some of you here will be involved in prisoner health one way or another, and so I think it's quite useful to remember that the NHS and health services are effectively mainly treating victims in hospitals and in trauma services, and we have the concept of prisoner health, don't we? But we rarely hear the term victim health, and I think there's a rebalancing that needs to happen there, and clearly from a health professional's point of view, especially someone who treats people like this, victim health and advocacy for victims is the kind of side that you're on. So now this is taking this now from the local to the global situation with violence, and this is these are data from the World Health Organization, which basically show us that violence is a problem for young people. So interpersonal violence, they're the 5th most common cause of death for those aged 15 to 29 worldwide, and that's excluding self-inflicted injuries and injuries sustained in wartime. So from a mortality point of view, as for an injury and harm point of view, this is generally an issue for young people around the world. The finding which set me off and set my team off on this idea that information from accident emergency departments could be used to prevent violence started here. We found in a data matching study, first of all in Cardiff and Swansea and subsequently in other cities, that only about 1/4 to 1/2 of violence which results in hospital treatment, that's accident emergency treatment, is actually known to the police. And that was a real shock, actually, to find this. And we didn't actually believe it to start with. We thought there must be something wrong with the data matching, but it's been replicated in several places now. And we also know that police recording, so police ascertainment, to use the public health term, varies by victim age and location and gender. So, for example, a 55-year-old woman who's assaulted on the street, that offence is very likely to appear in police records because it'll be reported. But an incident in a nightclub at 2 o'clock in the morning in which an 18-year-old is injured is unlikely to be ascertained by the police for various reasons that I'll come on to. And in case we think that this is something peculiar to a few cities in the west of the UK. Actually, if you look at the crime survey for England and Wales, BCS as was, and the International Victimisation Survey and country victim surveys, for example, in Sweden, we find actually that the same kind of proportion of violence is not reported to the police, does not appear in police records. So actually this finding locally turns out to hold water internationally when we look at the crime survey data through that prism. And we can't assume that it's just the minor offences which the police don't get to know about. So for instance, in the looking at the second bullet point there, that's 13% of shootings which resulted in hospitalisation in Atlanta, and Art Kellerman is an A&E doctor in Atlanta, did not appear in citywide police records. So, you know, that's really the most serious end of violence. So this is not a problem which is just limited to minor offences, the odd cut and bruise. This is includes seriously injured people as well. Now, what are the reasons for this? So when we discovered this, when we found this, we thought, well, it's a real shock. We've got to understand why. So went to the ESRC, got a research grant, looked at this formally, and this lack of police knowledge of a lot of violence generally reflects a lack of reporting for various reasons. So people don't report because they're afraid of reprisals, and of course the domestic violence example comes instantly to mind, doesn't it? Largely women, of course, don't often report, or often don't report violence because of fear of reprisals. People don't report because they don't know who hit them. So on a dark nightclub dance floor in a dark alleyway, if people don't know who hit them, they can't identify the assailant, and then they think, well, what's the point of going to the police? What can the police do if I can't identify the person who hit me? And then, of course, there's the issue of having one's own conduct scrutinised. If everybody's intoxicated, or all parties in an assault are heavily intoxicated, and it's effectively a fight where somebody gets put in hospital, then the injured person probably isn't want to have their own conduct scrutinised too much. Now, the second bullet point there, non-recording of reported incidents, this used to be a bigger problem than it is now, because the introduction of the National Crime Recording Standard across police forces in England and Wales, as we'll see in a minute from a graph, actually brought some uniformity to the police recording of incidents that were reported to them. So it's not so much of a problem as it used to be, and I think the introduction of the NCRS, the National Crime Recording Standard, actually has done a lot to bring uniformity and to make sure that recording is ethical, to use a word that one hears in the police service quite a lot these days. Sounds good, doesn't it? Promising. Anyway, so these findings together, what do they point to? Well, they point to the opportunity to use a new data set for tackling violence, and we can use that data set from accidents in emergency in two ways, really. We can use it as a new national and regional violence measure, so that we then triangulate violence measurements. So we've got the Crime Survey for England and Wales, police records, and now A&E data. So that triangulation helps to resolve difficulties and confusion and contradictions in the data from the other two sources. Electronic recording of these data by the reception staff when patients first attended was the best way to do this, and that's possible on a 24-hour, 365-day-a-year basis, because of course those reception staff are always in the A&E there, and this is ED. Sorry, this is the American E. So this is emergency department. So for ED, read A&E. So that's important, and that is a sustainable way of collecting the data. And then step two, anonymisation and data sharing by the hospital IT staff according to the rules and ethical framework to do with information sharing. And of course the important word there is anonymisation. We need to strip out all the things that just haven't been evaluated. We want to be instituting effective things, and that means things which are tried and tested in a rigorous way. So what's it about? It's about targeted policing, targeted street patrols, CCTV deployment, redeployment of police from suburbs into the city centre at night in a judicious way, so that the suburbs aren't denuded of police presence, but that the police follow or are deployed where violence is most likely. Plastic glassware, sort of ordinary glass, fast food outlet relocation, because fast food outlets can be a focus for violence. Then pedestrianisation of entertainment streets. This is just a few examples here. So one or two case studies, just to put some flesh on the bones, as it were. And this is taken from, this is a study which was published in a nursing journal, actually, Claire Dines in the southeast. And she collected up a number of case studies where this data had made a difference. So A&E information identifies a source of blunt weapons, which was a construction site next to a nightclub with skips containing bricks, concrete blocks and pieces of wood, which was then used as weapons, and the skips were removed. The second one here, in Northampton, the local authorities switched off some street lights as a cost-cutting exercise, and then the A&E data actually showed some violence happening in a particular street, and then the effect of that was to actually switch the lights back on. What effects has it had in numerical terms? Well, in terms of hospital admissions, it's compared to cities where the information sharing hasn't been done. It saves around, in our city, around 240 hospital admissions in a year. So hospital admissions down in the intervention city and up in the comparator cities. Cost benefit analysis, the annual cost of putting this information sharing enterprise together was about £5,000, and the annual cost of the woundings avoided, the benefits, about £800,000. So the cost benefit ratio, if you cost out all the health costs and the crime and justice costs, is very favourable. When you think about it, A&E doctors, trauma surgeons and police officers got very much the same kind of outlook on life, although they're in very different public services, action orientated practitioners. So I think there's something about that dynamic which is important. So having someone who treats the injured in the partnership, prompting the activity, prompting the prevention, I think is more helpful than not having that person there and just relying on the analyst or a local government official to do that. Now, this information sharing enterprise is actually now embodied in a professional guideline for A&E doctors. The College of Emergency Medicine here, that's the professional body for A&E doctors, and they published a guideline on information sharing which summarises the enterprise that I've been talking about. So that's helpful. So if there's an A&E department near you where you don't think this is happening, then this can be deployed to good effect, I hope. What are the pitfalls? Now, it's a fairly simple process. Remember those steps of collecting the information through to using it. But it's still a process which needs to be managed, and so good leadership in the partnership and good management of that process is important. There's no good devolving this responsibility to a very junior official who hasn't got the clout to make sure that the whole thing is joined up. Low data quality can be an issue. You need to have the locations there recorded consistently. Then poor analysis. If you don't have an analyst, then the data can't be analysed and you can't come up with a picture of the hotspots. Next pitfall, information's not used. There's no point in doing this if it's not used, and it's very important that everybody in the process gets to know why they're doing it. And actually, the receptionists in the hospital that I work in are motivated to do this because of the safety issues about their own family. We compared toughened beer glasses with non-toughened and found that the tougher the glass, the fewer the injuries, not surprisingly. And then we started with what we call the Face of Wales campaign, and which ended up with the industry switching over to toughened glass in the late 90s, and that had an obvious effect on the numbers of injuries overall. And this isn't a huge problem, but probably about 10% of people who go to A&E after a violent incident have been injured with glasses or bottles. And we have very good alternatives to glass now. This is one example. And so remember that Damilola Taylor, the 14-year-old in Peckham, he was actually killed with a supermarket lager bottle, and I was an expert witness in the trial of the Preddy brothers who were convicted of manslaughter for doing this, and this is a forensic science service reconstruction, and it's preventable. It's preventable with these kind of things, and also with making sure that glass is collected so that streets are not littered with glass, and the street pastors do a great job in many cities clearing the glass. And if we had a recycling scheme, if Tesco's extended their recycling scheme to give out points or a few p for glass, then that would, if European cities got anything to go by, result in continuous clearing up of glass, and there'll be less opportunity for this kind of thing. The Police Institute in Cardiff has done some great things in a short time. Neighbourhood policing, mapping fear of crime and concerns about crime, masterclasses with the Chief Constable and his senior management team to pass on that information, and they've done some terrific work. And so the question arises, last slide, what if university schools become the research and education foundations of probation services as well? And I know that probation services are in huge flux at the moment, but it seems to me, however they're commissioned, however they're organised, we still need a steady stream of reliable evidence from rigorous evaluation about what works to rehabilitate offenders.